of the New England Sleep Seminar. As you may know, our program now incorporates, in addition to the Yale School of Medicine, the Harvard programs, including the Beth Israel Lahey, Mass General, Brigham and Women's, Tufts, Boston Medical, and now our latest member, the Brown Medical School. And so hopefully you guys have had a good couple of weeks to rest and get some additional motivation for the work that's coming in the winter and the spring. And today we have a very nice special lecture. And I'm gonna hand the reins over to Dr. Ari Grover to introduce our speaker for the day. All right, take it over, Ari.
Thank you, Andre. Happy New Year, everyone. It's my pleasure to introduce Dr. Maria Sokolina. She is from New York. She's the founder and CEO of Harmony Dental Arts in New York City. Dr. Maria Sokolina is dedicated to creating a healthier world by promoting sound sleep and healthy breathing. She's originally from Russia. She graduated from medical school with a dental degree there. And she came to New York and received her DDS degree from NYU. College of Dentistry. She has extensive expertise in implants, cosmetic dentistry, full mouth rehab, orthodontics. She's very involved in teaching and finding solutions for sleep apnea through dental appliances and myofunctional therapy. She has an amazing Facebook group as well as a YouTube channel where she has a lot of talks and interviews a lot of dental professionals and medical professionals in sleep disorder breathing. She is a diplomat of American Academy of Dental Sleep Medicine. She has served on the board of American Academy of Dental Sleep Medicine and TEDx. She's passionate about sharing knowledge through lectures and articles tailored for both general and medical audiences. And she has been recently published in Forbes, AARP, and Sleep Review, among the other prestigious outlets. So with no further ado, Dr. Sokolina, here's to you. So please put your questions in the chat and we'll have some time at the end to ask her some questions. Thank you.
Good afternoon. First of all, I'm really honored to be here, and big thank you to Dr. Grover, who made it all happen. And I'm a dentist, and I'm going to present the lecture, which I want to serve as a bridge between medical and dental community. I know there is a certain stigma towards my profession, but I want to change that view, and that's why I write for high-profile publication and do a lot of social media work, and I put, picture of my channel. Because I think as a dentist, we have that unique opportunity to see signs of sleep apnea so close to our eyes. In addition to that, we have a luxury comparing to medical doctors. We see patients every 3 to 4 months, and we have a whole team, and we have much more time to spend with the patient. So we develop totally different trustful relationship with the patient. But there are a lot of challenges. And my questions, what I put on the screen, why don't all the dentists involved in the treatment of obstructive sleep apnea? And in my lecture, I'm going to try to explain why. And as you know, in the United States, 33% of men and 70% of women have a apnea-hypopnea index more than 5. And standard therapy, as you all use in everyday practice, would be the CPAP machine. And it's a wonderful therapy and it's really working well, but not a lot of patients find it convenient, or it's not such a high compliance. And according to the literature, adherence to the machine is just 4 hours at night. And after 1 year, the adherence and use of that machine is really dropped significantly. But there is such a link, according to the studies, between sleep disorders and general health. And for me personally, I see the whole medical history when I interview my sleep apnea patients. Not they have only sleep apnea, they have sleep apnea and high blood pressure and atrial fibrillation and diabetes and obesity, depression, heart attack, stroke, a lot of allergies and sinus infection. So it's basically like a medical book. And a lot of people ask me why. Why do I start doing dental sleep therapy? And I'm going to explain you this all come from fear. I've been doing the obstructive sleep apnea treatments in my practice for 15 years. And in the beginning, it didn't start like that. When I finished, I graduated, just like Artie mentioned, I graduated from medical school with a dental degree in Russia, and we learn about dentistry through the medical eye. So I have a lot of knowledge about the human body. And then I moved to United States and I graduated from NYU and I did the residency in Newark, Beth Israel, where I treat a lot of medically compromised patients. But then I start looking for my own pathway in dentistry. And I had such a huge imposter syndrome. I was so scared what I'm going to do the restoration for the patients and they're going to break it. So I took a lot of aesthetic courses. I'm very aesthetic person. I like to create beautiful smile. And I thought maybe if I'm going to learn how to use very strong materials, people not going to break it. But guess what? They still did. And then I took orthodontic courses. I thought, okay, I'm going to use the strong materials and I'm going to position teeth in the right way. I'm going to create a good occlusion. That's what we call the bite. And then they're not going to break it. No, they still did. And I had nightmares about that. But then on my course, on ortho course, I took ortho residency. I learned about sleep. I learned what if people have a sleep apnea episode and they cannot breathe at night, they're gonna break anything and everything to move the jaw forward to be able to breathe. And then I thought maybe that's my calling. I'm gonna help people sleep better. But you know how life is very unpredictable. And another event happened which really shaped my life. This is my friend who fell asleep in the age 47 on Saturday night, and he did not wake up on Sunday. He was really famous for two things. He had a great sense of humor, and he snored really loud. So then I realized what maybe my mission is actually saving people's life. And as a dentist who is practicing dental sleep medicine, I can do that because I see the signs of bruxism, a scallop tongue, edematous uvula, signs of acid reflux. I see erosion on the teeth, which are signs of that acid reflux, and a big tonsil so close to my eyes. And people complain on the allergies, and they cannot breathe through the nose. And that's how I started. So my typical patient who I meet on the screen actually, or in the practice, they complain on snoring, excessive daytime sleepiness, insomnia, multiple interruption of sleep at night. And they say very standard thing. I'm sure you hear it every single day. I feel so tired. I cannot focus. I want to wake up refreshed. My wife doesn't want to sleep with me in the same bed. I have no energy to go through the day. I wake up tired. And I ask them that question to really understand the story. If I have a magic wand and I can change something about your sleep, what do you want me to change? And now I'm going to talk to you about what I actually see in the patient's mouth in the patients who have a sleep apnea, what actually the physical representation. And due to the fact I have a channel on the Facebook, I interview a lot of health professionals and I get a lot of wonderful ideas. So there is acronym called NEST. And we're going to go through the acronym. Unfortunately, I cannot interact so much with you on a screen, but we start with the N. And the N is a narrow arches. The arches are so narrow, what tongue actually migrate into the airway and block the airway. And this is extreme cases, but people nowadays have a very narrow arches. And the second is E. It's enlarged tonsils and adenoids. And, I put the kissing tonsils there, but they don't have to be that huge to still make people snore and block the airway when airway relax at night. And then soft palate and uvula. And the uvula, what I see in the patient's mouth, they are huge. They are bulbous. They vibrate all night. And then I see these enormous sizes of uvula. And then also can be really long and obstruct the airway. And most of my patients have Malampati 4. And T goes for tethered oral tissue. And I put here two different representations. It's a tongue tie. I know it's a controversial topic. Some people are interested, but I have to admit a lot of my patients have, sleep apnea patients have a tongue tie, but tongue is not fully mobile and they cannot bring back portion of the tongue to the roof of the mouth, which is very important for creating that suction. And this is another thing which I actually noticed after COVID pandemic, I see more of it. This is called exostosis. This is mandibulatory, which also occupy the space for the tongue, and that happens from clenching. A lot of my patients have this huge, enormous, pieces in the mouth. And scallop tongue. That happened, this is a beautiful piston tongue, happened from pushing the tongue through the teeth upon swallowing, instead of holding on the roof of the mouth. And now I'm gonna do my two favorite signs. They're not part of NET, but I see them all the time. Mouth breathing. As a dentist, I see mouth breathing right away. It's a very specific look, how gum look in the mouth. It look very puffy, even sometimes bluish in the front. And in the back, it look okay, it look pink and it doesn't bleed much. So from the fact what air touching the gum from mouth breathing, gum becomes so inflamed and it bleeds. And then the second thing, yes, I do look at the nose and I see huge turbinate. It can be in both nostrils or in one nostril. But another thing, I want to talk about ala of the nose. They are much thicker for people who breathe through the mouth. And people complain on postnasal drip. They feel they have a sinus infection almost every month. And as a dentist, it's really challenging to treat people who breathe through the mouth because they have a tendency to gag and they feel very uncomfortable because they're fighting for the breath during the dental procedure. And that's how I can explain the fear of dentists, because person doesn't feel they have a full control of most important function, which is breathing. And this one, teeth grinding, we call it bruxism. When I was in dental school, of course, for the dentist, it's a nightmare. Teeth are small and the dentin is exposed, soft part of the tooth. People break the teeth so easily, and they taught us to do the night guard. But I even wrote the article for for the Journal of Dental Economics, how dentists obligated to check or to refer people who have a bruxism for sleep study, and instead of providing them the night guard, what occupying space for the tongue, maybe it would be the better service to work with the medical community and offer the oral appliance. And here I put the articles what show a direct correlation between both ways, between sleep apnea and bruxism and vice versa. People who have a bruxism, 73% of them have a sleep apnea, and sleep bruxism has a very high correlation of sleep apnea. Depends on the degree of sleep apnea between mild, moderate, and severe. So for dentists who see the signs of bruxism, it's very important to collaborate with you, to send you the patients and ask for sleep study. And, as a dentist, we have several most common disease what we see in a patient mouth. I put the articles what demonstrate correlation between periodontal disease and obstructive sleep apnea. Actually, periodontal disease and mild sleep apnea, they're more frequent in the women who have a hypertension and hypertensive cardiomyopathy. And it's also periodontitis associated with a severe sleep apnea in men who have a, also those two comorbidities. So it's a little gender difference, but the fact is what it's necessary to perform dental evaluation. And then if dentist suspect sleep apnea, refer. And in my office, I start doing salivary tests because composition of the bacteria in the mouth for people who have a sleep apnea also different. There is a different bacteria what live in the absence of nitric oxide, and just based on the combination of bacteria, it also can give some ideas about sleep apnea possibility. And the last one called malocclusion, bad bite. The bad bite play important role in the development of sleep apnea as well, especially for individuals who are not obese. And for me, as a philosophical person, I always try to find the reason why so many people in the present time have a sleep apnea. And I love to go to anthropology museums and look at the skulls of people who live before us, before industrial revolution. And I'm always admiring big, wide jaws with enough space for all the teeth, including the wisdom teeth. Right now, removal of the wisdom teeth is like sign, one of the stages of growing up, as well as orthodontic treatment. Almost every child have to have orthodontic treatment. What it illustrates, what it's not enough space in the jaw for all the teeth. And I'm always wondering why. And, over here, I'm going to just illustrate two possible reasons. We start with the breastfeeding. In the ancient time, if baby cannot be breastfed, it would simply die. But right now, totally different story. We have a bottle and mom have to go to work. So it's totally different impact of that sucking, swallowing when a baby gets fed by the breast comparing to the bottle. It's so much less effort. In addition to that, the antibodies and the amount of allergies for the babies who did not have a breast milk, it's significantly higher. So we're talking about mouth breathing and a different position of the tongue. And another factor would be the nutrition. Famous American diet, ultra processed food. I find direct correlation with the amount of allergies among my patients. When I was growing up in Russia, we really did not have that many allergies as it is right now. And this is the line to McDonald's, which was first brought, to Soviet Union, and people find it, extremely delicious. It's a delicious food. It leads to some consequences. And I'm going to talk about risk factors for sleep apnea. You probably know it's excess weight, neck circumferences, narrow airway, male gender, family history. People usually come to me and say, I snore, my father snore, my grandfather snore. Smoking leads to swelling of oral tissue, and my two favorite ones, nasal congestion and history of allergy and asthma. I find what a lot of people who have asthma, they also breathe through the mouth. And now, why not all dentists involved in the treatment of sleep apnea? Because dentists need two things to have that treatment, among others. But we start with it in the beginning. Dentists cannot diagnose sleep apnea, so dentists need referral from the medical office and sleep study, which less than 5 years old. That's why it's so important to collaborate with you. And here I put the white paper. This is the rules according to American Academy of Dental Sleep Medicine, how this whole collaboration have to happen. So American Academy of Sleep Medicine and American Academy of Dental Sleep Medicine recommends that sleep physicians prescribe oral appliance therapy for mild and moderate sleep apnea, and patient does not have to fail the CPAP in that case. So it's according to official requirements. I know some insurances have a totally different requirements. I learned that too. And they have to be custom-made titratable oral appliances rather than non-custom made device what patient can buy on Amazon or in the pharmacy. And also what qualified dentists provide oversight rather than no follow-up. So active treatment, usually we say active treatment after dentist prescribe oral appliance to the patient, approximately 3 months. And then dentists have to refer patient back to sleep physicians to check the results with the sleep study. And after that, sleep physicians have to follow up that patient once a year. And dentists have to see the patients every 6 months for the first year and once a year afterwards. And every 5 years, or in case of weight fluctuation, sleep study have to be repeated. And I know it's I find it difficult areas because dentists have to learn how to be part of a medical community. And to make it easier, I create my social media presence, that I put a picture of my Facebook group where patients can communicate with the physician. And I have a lot of interviews to build the bridges between medical and dental community. And now I'm going to talk about specific how I do oral appliance therapy in my practice. So there are 126 different sleep appliances on the market, but there are 2 categories. One is a tongue retaining device, what moves the tongue forward out of the airway and it stays, kind of in the appliance. Similar idea how Inspire works, but it's a little bit much more restrictive. And the second choice is a mandibular advancement device, what moves the jaw forward with the tongue. And in the same time, by moving the jaw forward, it makes the airway more tongue, what it does not collapse so easily. And in my office, I usually start the collaboration with the patient after, my staff get all the information, referral from the medical doctor and sleep study for us to have a conversation with a virtual conversation. I know there is a very, patient love telemedicine. Physicians sometimes have, certain objections against it. I totally understand because it's difficult to arrange. But I find especially because I'm a dentist, what patients feel much more comfortable in the comfort of their own home to really explain to me what's going on and what really I need the magic wand for. And a significant part of treatment is a financial concern. I don't discuss financial concern, but I have a medical department who make that part also known to the patient and offer them a different strategy how to make this treatment successful and financially successful. And a very important part, what I find out during my virtual conversation about other doctors who involve in a patient care, because I want to keep all my medical doctors, my team of collaborators in a loop, because sleep is a team sport. And after we're done with initial consultation and patient is ready to proceed with the treatment, we do digital flow. I do the comprehensive exam, and then we have a 3D X-ray, and I take a different, I had a neck X-ray to be able to evaluate sinuses, temporomandibular joints, turbinate, airway side, and then we take a scan using the digital scanner, and I set up the bite. I have a very common question from medical community. How far I move the mandibular forward? And I have a clear answer on that. My first goal in the treatment to make patient comfortable. That's why I move the jaw forward to the position what patient find comfortable. I don't want patient to have that aversion towards oral appliance. I want them to become friends with appliance, and then I can move the jaw forward for whatever position I think gonna open the airway the best. Then now the appliance selection. I do help people who have Medicare. I'm a provider for Medicare, and Medicare dictates the rules. I have to use this certain design. It's called herbs and top. I use mostly herbs for people who have a Medicare. And some people, or just like I mentioned, have a temporomandibular joint problem. And for them, or they might be just very, very sensitive to any change. For them, I try to do titration in a minimal position. So this particular device, I can use the screw and move the jaw 0.2 millimeters. And I have no rush. I just want to make sure that patient is comfortable. Then I have a lot of drivers in my practice. And some people drive the plane, some people drive the train, and some people drive the bus. And for them, they need to have a report to renew the license. So I include the chip in the oral appliance, which show me the compliance with oral appliance. But this is a technology and it's developing. And now SomnoMed work on a chip what can also show AHI. So sort of like a CPAP machine card reading. I read with a special machine in the office, and it fabricates this report. In this particular case, show how many hours and how many days patient is wearing it. And then in the future, it's going to have AHI as well. But a lot of my patients, just like I mentioned, they are severe clenchers and bruxers. They put a lot of forces on the appliance. And also, they want to have appliance as thin as possible. So this is the appliance what as thin as a clear aligners and made from printed nylon. It's very durable. According to the lab, patient cannot break it, which is not true. Patient still can break it, but it's very difficult. And it doesn't have any intrusion on the cheek. So it's much easier for patients to sleep. And as I mentioned in the beginning, I'm a very aesthetic person, and I like to approach my cases comprehensively and to understand what I can do to create more space in the mouth for a tongue. So I use the combination appliance, orthodontic treatment and oral appliance. This is the example how it looked like. And this is a beautiful story about the child who came to me after his wife passed away. And he spent, he devoted many years of taking care of his wife. And in addition to sleep apnea, and he was not able to use the CPAP machine, his teeth got really broken down and it was dentin showing. So I did the combination treatment while I was controlling sleep apnea. I create a favorable prosthetic situation, and I was able to restore his teeth while he was wearing oral appliance, what he can start a new chapter in his life, I hope. And this is another design of oral appliance, what I can use with the clear aligners. And this is just for the bottom. It has a certain part what holding the upper jaw. And this one, two extensions on the top. They making the nostrils bigger underneath the lip. And this one holding the tongue to prevent it collapsing in the airway. So this appliance has a lot of components, and I can utilize them when I use this one. And also I can use oral appliances and clear aligners in preparation for orthodontic surgery. Some patients would like to address sleep apnea using a maxillomandibular advancement surgery, but for that, oral surgeon need to have teeth aligned. And I can do it using the oral appliance to control the apnea, and in the same time, have a clear aligners to align the teeth. actually after orthodontic surgery, they cannot use oral appliance. If it's not fully addressed the sleep apnea, they have to use the CPAP. And this is how I do it with the digital treatment planning. Using, I can communicate with the technician and move the teeth according to my strategy. A lot of physicians ask me about the bite change. They don't want patients to complain on a bite. So after patient use oral appliance at night, they have to use AM positioner for 10 minutes in the morning. And I put a different design. I made them in the same time when I deliver oral appliance and give instruction. And a lot of physicians also concerned about pain in the jaw joint. And yes, it can happen. But according to my experience, it usually happens with people who clench the teeth during the day. And, of course, I instruct them to keep the teeth apart, just lips together. But we also have a whole program. I have a video, what I give it to them, what they can do the exercise to relieve the pain. And we teach them how to use special warm compresses before the night and after the night, and massage with the heat and vibration. And I also give them naproxen in case if they have a lot of pain. And now this is another very common question what physicians want to know, if oral appliance therapy covered by insurance. Yes, it is covered by medical insurance, not by dental. And it's another learning curve for dentists to overcome, I would say, because we used to deal with the dental insurance, and medical insurance is totally different zone. And in my office, I have a medical department, and I also have a billing team what helps to bill oral appliance. But not all oral appliance therapy work 100%. And I try to find out if that can happen on my initial consultation. If somebody cannot breathe with the nose, or a lot of people don't have an idea how they breathe, but I can have a clue how they breathe, we talk about opening up the nose using a special irrigation with saline or xylitol. I offer them Navash or nail med bottle. They can purchase and start using it even before the oral appliance. And then I highly believe in the nose breathing. And I talk about nose patency. And I love that story when patients come to me and say, my septum is deviated. And I know I'm very small on the screen, but I'm a queen of deviated septum. My septum is deviated like no tomorrow, but I just, determined to breathe through the nose only. But for people who cannot, I offer them, we explain to them, my team explained to them about mute. This is a soft silicone ring what they can put in the nose, and it's actually opening it up. But to make it easier, we teach them how to use it with a special gel to make, that ring go in without any friction. And I'm a big proponent of mouth tape. I notice if patients have a habitual mouth breathing, the lips, muscles of the lips, they become so weak. And a lot of people, they snore and they complain on a dry mouth. So we teach them after they clean the nose, but they can use the mouth tape to keep the mouth closed. And it significantly improves the result, because the phenomena is the following. If somebody has a mouth closed, then tongue stay forward. As soon as they open the mouth, tongue fall in the airway. And it's not a torture chamber, and the tape doesn't have to be, barbaric. It can go just around the lips, and it's enough to keep the mouth closed. But I want to tell you this story about my patient Ted, who, life is long, and sleep apnea is a progressive disease. And if somebody, just like him, I met him in a pulmonologist office, he started with a CPAP machine because his wife was so concerned about his snoring and stopped breathing. But when I met him on a consultation about CPAP therapy, he said, fine. He was using a CPAP therapy. But then he was referred to me because he said, I'm traveling a lot and I cannot wear the CPAP all the time. So I offered him oral appliances. And then we did the sleep study. He was very successful with oral appliance. But after, I would say 3 years, he came back to me and said, I don't want to use the CPAP machine and I don't want to use the oral appliance. And I said, oh, you can combine, you can use CPAP certain nights, you can use oral appliance. And he said, no, you have to find out something else. I don't want to do Inspire. I don't want to do orthodontic surgery. So for him specifically, I start offering myofunctional therapy in my practice. In his case, I did it in combination with orthodontics. I know a lot of physicians are very curious about myofunctional therapy. So this is a therapy what help tongue to stay on the roof of the mouth, to swallow just with the tongue, to breathe through the nose and hold the lips together. And this is the whole idea behind myofunctional therapy. According to the research, if tongue stay lightly suctioned to the palate, then other tissues are going to be kind of suction to the tongue, because tongue is such a huge surface and it has negative charge. So the lips positive charge, uvula positive charge, they all stay together and airway stay open. And yes, we did myofunctional therapy for 6 months. We meet with Ted every 2 weeks and gave him a new set of exercise, and he was doing it twice a day, just devoted to myofunctional therapy, 5 minutes in the morning, 5 minutes at night. And to huge surprise of his pulmonologist, his AHI from 20 become 1.4. And in additional benefit to that, he is a clarinet player, and with the opportunity to use his muscles, because fitness should not stop on the clavicle level, he becomes a better clarinet player. And I put myofunctional therapy goals, and I actually published the article in the Sleep Review magazine about a different modality of treatment through the patient lifetime, because life changes, circumstances changes, as well as the treatment what patients want. And just like I mentioned, tongue on the spot, lips together, breathing through the nose, and correct swallowing. It's a very challenging, it's a difficult to change that routine for adults. We start with the kids, but we do it for adults, and a lot of adults benefit significantly, not only for oral appliance therapy, as they also benefited with the CPAP treatment. If they can breathe through the nose and keep the lips together, the CPAP become, you don't have to use so much pressure. It's become so much more effective. And you can try these both techniques. A lot of my patients who habitually breathe through the mouth, they have to keep the tongue low to keep the airway open for the air to get in. And we try to change that modality and make them keep the tongue on the roof of the mouth and breathe through the nose. It's very challenging, true, but if people put the heart into that, they can do it. And I always try to make my treatment interesting. So I use a lot of accountability coaching. All my patients get this application called SnoreLab, and they can measure the snoring before the oral appliance therapy or before myofunctional therapy, and then with treatment. And there is another one, Go to Sleep. That's a ring what actually measure AHI. And if patient has some type of wearables, I try to incorporate it into that accountability coaching. And I'm very big, I'm really into the AI. I really find what help of AI can make our treatment much more personalized. And specifically, I use the power of AI to create the letters to the patient and to my collaborators. I try to explain to them what type of treatment I do and show them before and after results after the sleep study. And if sleep study is not so good, what type of treatment I'm going to do to make it better. And then with those letters, I find so much better understanding with my patients and with my physician collaborators, because I want them to understand what step I'm going to make if AHI is not less than 5. And strategy can be very different. It can be advancement of oral appliance. It can be myofunctional therapy. In some cases, I refer patients to physical therapists to improve forward head posture. That's also improved the breathing. And I collaborate a lot with ENT for tonsils removal, for correction of deviated septum. And going back to my friend passed away from a cardiac arrest, which was accentuated with by his sleep apnea episode. And I really hope what collaboration between dentists and physicians can not reverse the situation, that's not possible, but can make positive impact on the people who walk around undiagnosed. 87% of people undiagnosed with the sleep apnea. So I hope what people like my friend will not fall asleep and never wake up. And to fulfill that mission, I write for a lot of publications. I write for dental publications and I write for lay people publications. It's just like Artie mentioned, my article was published in Forbes and AARP and the Med Shadow Foundation. And I would be very honored to connect with you, and if you can become part of my community and share your sleep airway treatment journey and your victories and your challenges. And if I can, I would love to help. And as a little gift, Debbie will send it to you, my myofunctional therapy and sleep quality self-assessment, and then you can get the video to understand what exactly myofunctional therapy is. And I also send it to her, temporomandibular joint self-assessment and video to make that better. So I really appreciate your attention, and I'm looking forward to answer the questions. If you have any questions, Debbie will provide you my email, and I'm going to try personally respond to all of them. Thank you.
Thank you, Dr. Sokolina. That was great. Before I start asking, I don't see any questions in the chat just yet.
I see. No, maybe it's not a question.
And so I have a question actually for you. I find, you talked briefly about myofunctional therapy for OSA. I guess, can we, as a medical sleep doctor, what's the role of myofunctional sleep therapy in these group of patients? Should we prescribe that as part of our, okay, you're going to use CPAP. Let's say patients are willing to use CPAP, but maybe myofunctional therapy could be part of the combination conversation we can have with these patients. I don't know if you have any thoughts about that. And if you have any thoughts about, in any way they're getting treated for sleep apnea, what's your thoughts about myofunctional therapy?
I'm a big proponent of a myofunctional therapy, just like I mentioned. And I think for people, a lot of sleep apnea people, they don't breathe through the nose and they keep the mouth open, which make CPAP treatment much more challenging. I know we use that, chin strap, but they still can open. With myofunctional therapy, you can improve existing treatment. And now I want to talk about technical aspects of that. There are a lot of myofunctional therapists around, and speech and language pathologists and some physical therapists, they also have a certification to become myofunctional to be myofunctional therapists. It's a little bit interesting now with boards and license. That's true. But if medical doctors support this initiative, that's going to become more streamlined. So if medical doctors see what patients struggling to breathe through the nose, struggling with nasal pillows, it would be wonderful if they mention myofunctional therapy. And I know a lot of myofunctional therapists, they want to collaborate with the medical doctors, but medical doctors are very busy people. So if they give this opportunity, and I can personally, I know you're in New England, and I have a lot of people who practice myofunctional therapy. I can connect. And myofunctional therapy does not have to happen in person. So if somebody feels comfortable with myofunctional therapy, and if it's a good match, because it has to be for 6 to 8 months, so it's a long process, then it can be done virtually.
And the patient that you mentioned talked about whose AHI dropped from 20 to 1.4, was that over what period of time with myofunctional therapy?
Myofunctional therapy, in my view, I like to have a structures and schemes. I like to organize everything. So we always present not endless treatment, like sometimes speech and language pathologists think about that. It has a 12 session. We time it every 2 weeks. So I consider what in 2 weeks patient gonna do the homework, and a muscle strength of a certain department gonna get stronger. We check the homework and can give them a next step. So the first half of myofunctional therapy is basically the exercise to make lips stronger, to keep the tongue on the roof of the mouth, to breathe through the nose. In the second half, we teach them how to incorporate those new skills through the drinking and eating, because they have to exercise the tongue and breathe through the nose while they drinking and eating and chewing, and while they using normal activity, they have to keep the tongue on the roof of the mouth. So it's I would say 3 months. It can be longer. Life is funny, life is difficult. So but we're talking about 6 to 8 months.
Thank you, and I thank you for sharing the video. It's in the chat. So there's a question: who does the myofunctional therapy work best for? Is the therapy exercise meant to be done long term? I think you mentioned 6 to 8 months. Also, how does the oral appliance keep track of the daily AHI? So there are two questions basically.
I start with the first question. Myofunctional therapy works best for the person who wants to really change. I know it's a very I want to say somebody who have mild AHI or moderate AHI or severe AHI. It's not that. It's what's inside. Is person willing to invest the time and invest the effort? They have to do it every day, 5 minutes in the morning, 5 minutes at night. It seems like nothing, but it's very difficult to put it in a routine. So I think it's not necessarily they're going to get the same results as a TED on a screen from 20 to 1.4, but they be able to learn to use the nose, for example. A lot of people consider it just a decoration. It's much easier for me to breathe through the mouth. I don't know how I breathe. I don't know why I even have that. So, if we be able to fundamentally change the idea, what the tongue have to stay on the roof, and you have to swallow without using all these muscles, which eventually going to lead to dental malocclusion, to crowding. Very often I find the relapse in orthodontic treatment due to the fact that myofunctional habits are wrong. So this is my answer. Yes, myofunctional therapy exercise has to be done lifetime, but not necessarily with a coach. You have to do the correct swallowing, breathing, keeping the lips together all your life. But we do check on the patients. We have a certain recall system with the myofunctional therapy. It's true, but just to refresh the knowledge, and science is not a closed book. We get the new toys, new strategies. So we like to share with our patient base. Now, oral appliance, how it keeps track of daily AHI. No, I don't keep track of daily AHI, unfortunately, in this present moment, because I know there is a chip what will track the AHI, but I never use it yet. It's in the process of FDA approval, and I would be the first one. I'm in a very close relationship with that company. I would be the first one to test it on my patients, but I did not test it yet. So what I use to see how my patients are doing, I use Epworth questionnaire, fatigue questionnaire, and Snorlab. If people invest in the ring or wearables, then we can track AHI. And some people do. Some people are very involved in the health journey, and they do that. But usually it's best to have a sleep study. All my patients, we discussed it in the beginning. after we're done with therapy, they have to have a sleep study in the end. And it doesn't mean in the end, like let's say 3 months. And it doesn't mean that it's always going to be below 5. That means if it's not below 5, we're going to continue with the strategy. And I see oral appliance therapy is a lifetime commitment. Just like any sleep apnea treatment, it's a progressive disease. If patients want to change, like if patient wants to get cured, I know maxillomandibular advancement can be the cure, but not 100%. I have patients who had the surgery done, but they still have residual sleep apnea. And Inspire, it's another option. And oral appliance is a lifetime commitment. If they want to use oral appliance for the lifetime, it's going to be the lifetime commitment. And my goal to prevent a bite change. So we check them every 6 months for the first year after the insertion of the appliance, and then once a year afterwards to make sure temporomandibular joint doesn't get resorbed, and to make sure bites stay the same. And if it's not, we offer them different strategy to address it, just like any type of treatment. We monitor it. And for me, medical doctor is always a captain on my team. So medical doctor gets reports every time I see the patient, and they might have concerns. And I try to stay really in close connection with my medical doctors through the text. So.
Thank you. Are there any other questions for Dr. Sokolina?
And I know I mentioned a couple things, like since it's no questions, maybe some people want to know how to find a dentist to work with. So I would like to illuminate that subject. I think it would be a great thing if medical doctors find the way to start a relationship with a dentist. So dentists, as a dentist, we get a lot of lectures on oral appliance therapy and dental sleep medicine. And a lot of people take 5, 6 courses, but they cannot start because no relationship. And it would be wonderful if relationship would be started from a medical doctor side. So there is American Academy of Dental Sleep Medicine, but has a list of the diplomats. I'm a diplomat, people who have a board certification. And there is a list of distinguished dentists who took the courses, but maybe didn't have enough cases, because, it's like a circle. If you don't do the cases, then you cannot do the board. And, like it's not only you have to do the case, you have to also have a sleep study done after each case. And that's another challenge. And when dentists, just like medical doctors, we have a lot on our shoulders, and it's very hard to convince the patient, and insurance doesn't pay. So these stories. So these distinguished dentists who would love to treat dental sleep medicine, not to have the same fear like I have when I finish my residency program. They don't want anything to break in a patient mouth, and they would like to protect the dentistry with oral appliance therapy to have it last for a long time. They would love to collaborate. And I have a funny story to tell you. If it's no questions, then I'm going to share my story, how I try to establish relationship with the medical community in the beginning. So, it's a lot of cold calls. So I had a mutual patient who said to me, I go to this specific doctor, and I did my research on that doctor, and I learned, I said, I really want to work with him. I think his expertise is fantastic, and he's not too far, so it's going to be convenient both ways. I can refer him for sleep study and referrals, and he referred back to me. He has a CPAP failure. So, like I strategically calculate everything. And I learned, but he's foodie. He likes, good food. So I said to him, I sent him, I reached out to him and said, why don't we have dinner on that day? And we went and we had dinner in the restaurant. So, you know, he ate his dinner and I presented with my models and my oral appliances and my articles. And I, you know, I did everything. I thought I was like a queen of the evening and he was listening and everything like, you know, seemed so wonderful. So we finished the dinner. I, you know, I take the check, you know, I arrange everything. And he said to me, you know, I really like our evening. It was so wonderful, but I'm not going to refer to you. I'm going to tell you because I like you so much. I'm not going to refer to you. And from that moment, I realized it doesn't matter. I can, you know, jump over the hoop. And if it's no relationship, no trust, that's not going to happen. So that's why I start my channel. And through the channel, when I interview a lot of medical doctors, I learn certain things that are so important to medical doctors to have, to be able to work with the dentist. So that's my story.
Thank you for sharing. I have another question I see. Any drug therapy for this condition? Is that, I don't know, is that for Dr. Sokolina?
The drug therapy, I know there is a very promising story with pharmacology now, but I heard from my patients who really looking for magic wand, for magic pill, what's gonna address the sleep apnea, but it's very difficult to get the insurance approval. So
Thank you. Yeah, well, thank you for this talk. I actually do have one more question. Can you share some data on the efficacy and effectiveness of the myofunctional therapy on treating sleep apnea? I mean, you've had wonderful anecdotes, which are very encouraging, and many patients are seeking this kind of treatment. But how well does it actually work? Have there been evaluations of this?
Yes, there is an article what oral appliance therapy decreased AHI by 50%. There is an article. I'll tell you this. Dr.
Oh, I mean, no,
Zagi,
I'm sorry. I mean, myofunctional therapy. You mean, I'm talking about the exercises that you were mentioning.
Myofunctional therapy. I'm
Yeah.
talking about myofunctional therapy. Dr. Zagi published the article where he studied 350 patients that was for the tongue tie release and myofunctional therapy. And he found what is very effective. But this is true. What there is right now, I cannot give you very specific statistics how effective myofunctional therapy for treatment of sleep apnea. I can only tell you what there are anecdotes, right? The cases what are very successful, and what this particular therapy helps within management with oral appliance therapy as well as the CPAP. I cannot tell you right now what it's myofunctional therapy gonna give a cure to the patient with the sleep apnea.
Oh, right. Thank you. And then if we were to have patients who are interested in myofunctional therapy, who would they refer to? What are some of the reputable practitioners out there that might be able to help?
I would suggest to go through the professional organization, International Association of Myofunctional Therapy. They have a board and they have a list of practitioners. IOMP, like I forgot the abbreviation, but it's International Association of Myofunctional Therapy. And I really appreciate one of the listeners, Dr. Po Yang Cho, who put the article, meta-analysis of effect of myofunctional therapy. This is actually Dr. Camacho. He's a Brazilian practitioner. He's very, knowledgeable on the effect of myofunctional therapy, and he showed what 50% of reduction of the obstructive sleep apnea for kids with myofunctional therapy. So, answer to your question, I would go through professional organization, International Association of Myofunctional Therapists, something like that.
Thank you again, Dr. Sokolina.
Hey, great. Thank you. So I think we'll have to wrap up. Thank you, everyone, for attending. Thank you, Dr. Sokolina, for giving us a tour de force of myofunctional therapy and oral appliance therapy and sleep apnea. And we look forward to our next session come February. Take care, everybody.
And thank you very much for the attention, and thank you very much to Dr. Groover for arranging.